Hello, Assalamu alaikum and good evening. Welcome to another episode of Health is Wealth. I am your host, Shabnam Riaz. In the last program, we spoke about, problems affecting the lungs or pulmonary diseases and issues. And there was just so much to talk about. Because of that, we've decided to continue the program and today as well speak about pulmonary issues. And for that, we again have the pleasure of our guest, Dr. Sajjad Nasir, pulmonologist and Principal Medical Officer for the Park Atomic Energy Commission Hospital. Thank you very much for taking out the time to be with us again today.
Thank you very much for the invitation again. It's a pleasure to be with you here again.
Likewise. Dr. Sajjad, in the last program, we spoke a lot about, smoking and other issues as well. Today, we're going to talk about diseases of the lungs and the different parts of the pulmonary system that are affected. So one thing we started talking about today, before we came in for recording, was tuberculosis. Mm-hmm. Now, exactly what is tuberculosis? And then we'll go on to the specifics behind it.
I think it's a very valid question, Shabnam, and tuberculosis, as we discussed before the program, is still endemic in Pakistan. So endemic is something which is, in terms of the census, it is prevalent in most of the population.
Okay.
Currently, Pakistan is standing number 5th in the whole world in terms of the TB burden disease. And that's a WHO sort of census and data. In terms of the resistant organisms, Pakistan is number 4th in the whole world. So it is rampant in Pakistan still. We are still having more than 450,000 cases annually of tuberculosis. Tuberculosis is a condition caused by a bacteria.
Okay.
And the name of the bacteria is Mycobacterium avium complex. And they call it complex because there are different subgroups of the same organism.
Okay.
The common organism we have is known as the typical Mycobacterium. And it's a type of bacteria which is a very slow-growing bacteria. So it's not like the common pneumonia or infection, which transmits very easily and starts to grow over, say, hours to days. It's one of those organisms which has got a very slow half-life, and it grows on the culture medium over 4 to 6 weeks.
Okay.
So it is, say if somebody gets the bacteria, say today, the symptoms might occur slowly over the time of next 4 to 8 weeks.
Okay.
So the take-home message for the audience is that if somebody is coughing,
okay. Is that the first indication?
It's
first
one of
symptom?
the first symptom.
Okay.
When the patient starts to, say, cough for at least more than 2 weeks.
And is that a sort of a dry cough, or what type of a cough would that be?
It could be dry, but predominantly people tend to bring up the sputum with it. So they might have a sputum, secretions coming up. The color of the sputum can be something from white to yellow to green to orange. And they might have blood in the sputum, depending how intense the infection of the tuberculosis is.
Right.
Because TB organisms, they sort of dig down into the breathing tubes, and they can cause very extensive damage. And they form a very small cavities in the lungs wherever they cause those damages.
Okay.
And that's why people might start to spit blood. And that's the alarming sign when most of the patients, they come down to see us. The other symptoms could be weight loss, because all the nutrition the patient is eating is being consumed by the organisms. They would have low-grade fever as compared to a high-grade fever,
okay.
Which people tend to get with the other infections. They can get sweating because of the systemic process. They will get the weight loss, and generally they would feel lethargic and tired. But I think the key thing is the duration of the symptoms, because the other symptoms can be due to the other infections. However, if the duration of all these symptoms is for more than 2 weeks, one has to start thinking and wondering about the tuberculosis.
Okay. So, we have a person who has these symptoms. What should they do next? They can see, should they go to a pulmonologist or go to a general physician? And then what sort of steps for diagnosing TB would take place?
I think it's a difficult question to answer in our part of the world. The reason is that the healthcare facilities are they're quite scattered, and they're not rationalized like emergency ERs that can invest, or the GPs.
They're not centralized.
They're
yes,
not
it's
centralized,
absolutely
and that was one of the bigger problems we came across in Pakistan. As I said, Pakistan is number 4th in terms of the drug-resistant TB, and that is because of the irrational practicing of overdiagnosing the TB and giving TB drugs to the people who may not need it in first place. And that's why WHO recently have put a ban on giving the TB drugs to the common pharmacist in Pakistan, and then trying to centralize it to the government
So
program.
it's now only available on prescription, is it?
It's only available on prescription through the central government outlets, say like
Okay.
from PIMS or Holy Family or Polyclinic,
Right.
and other sort of designated private and public places.
Which is a good thing.
Which is a very good thing.
Yeah.
It's a very good thing. So I think coming back to your question of how we should approach it, I think if it's through the general practice or it's through the specialist, the first thing is that they have to ask for help.
Right.
And the second step would be ascertaining from the history, and the important thing in the history is because a droplet infection, it transmits from one person to the another person living in the same close quarters. So we have to ascertain whether any family member, any colleague working in the same environment had TB in the past. And depending on the history, the next step would be to go for a chest X-ray, checking the sputum for the TB organisms. And then there are some blood tests which we can do to ascertain whether there is any active or hidden or latent TB. And based on these different tests and investigations, we can plan few other investigations, but these are sort of initial baseline investigations, which normally gives an answer in 60 to 70% of the patient group. And
Okay.
if any of these tests are positive, then they have to go for the TB treatment, which is normally for about 6 months.
6 months.
6
That's
months.
quite some time.
And
What
the-
does that involve?
I think the problem with the TB organisms is they're very, very clever bugs. So as we know that they are slow growing, they grow over the period of 4 to 6 weeks. They don't multiply that quickly like other organisms. And when they come into our body registers them that they have entered into the body through our defense system. And if the person is young and robust, the defense system would try to contain the organisms into the, I would say, the tombs, the hidden tombs known as granulomas,
Okay.
where our defense system, the cells, they capture them and imprison them in those granulomas.
Okay.
Now, for any reason, if they, if the patient is weak because of any reason, say like diabetes, any heart condition, because of age, because of pregnancy, because of taking some other medications, they might overcome their defense system and they would start to multiply and cause symptoms. And that is when you call them having active TB.
Okay.
On the other hand, if the person is robust with no other medical condition, with a good strong system, that organisms would be contained in those granulomas.
Okay.
And
so
that is-
that's how you become a carrier.
This is how you get a carrier, or what we call it a latent TB or a
Okay.
hidden TB.
Okay.
A carrier is something different. Carrier is that, that is what we speak more in terms of viruses. So a carrier is who is not himself active, but he can give infection to the others. In terms of TB, if it's hidden TB or a latent TB, they don't give infection to anyone else. It stays in their body, maybe for the rest of their life,
Okay.
without causing any damage.
Okay.
On the other hand, at some stage in their life, if they get their defense system a bit weakened up, say because of age, because of any other infection, say because of diabetes or any heart condition, or because of any medication, the organisms might come out of their tomb and they would spread to the body and cause active infection.
Okay.
So we have to differentiate between the active TB and a latent or a hidden TB, which is something different. And the treatment is different for both of these conditions as well.
Okay. Now, having said all that, how exactly do you get TB? How is it spread?
As I said, the TB organisms, we call them a complex. And the complex is because there are different types of subspecies of the TB organisms. If I try to specify it more in terms of the common or the typical mycobacterium, it spreads primarily by the droplet infection. So say if somebody is living in the same close quarters, say the family members or the colleagues, or if you're working in a workplace with someone who has got an active TB, who's spitting out the TB organisms in the secretions, then it's due to the droplet infection. So if you spit somewhere, the droplet sits there, and if you're nearby, and if you inhale those organisms, that might go through the breathing tubes down to your lungs. The other common mechanism is through the placenta, from mother to the fetus. And then there are different, subtypes of TB, like the bovine TB. It's getting rare, but still, people living in the rural areas can get what we call it bovine TB, which is happening through the ingestion of the contaminant milk. And that TB is transmitted from the animals to the human beings by drinking the contaminant milk. Then, the rare subtype is more common in US and UK and the West is the atypical TB, and that is an environmental bug. So that is sitting in the environment. And say if you get immune compromised due to any reason, say like HIV, because of drugs, you can easily catch those infections from the environment. They wouldn't affect the normal people with the normal immune system, but they would affect the people with the weaker immune system. So I think just to summarize, it spreads primarily the typical one with the droplet infections by having a close contact from mother to fetus through ingestion of the contaminant milk. And lastly, it could be environmental organisms affecting people who've got weakened immune system.
Okay. What about utensils, sharing spoons, glasses, things like that?
I think, as we discussed previously, there are quite a few myths, and myths are myths. Okay, so in terms of scientific things, if somebody has got an active TB, which I've said in the beginning is something completely different. Active TB is, say, if the organisms are they are dominating the body, and they are destroying our breathing tubes, and as a result they're coming into our secretions, and the secretions are going out, and if somebody is, say, spitting or throwing their saliva, so if I'm saying this cup of tea with my saliva going in, and if somebody else living with me drinks through the same saliva, having active TB,
you've passed it on.
they'll pass it through. So that is only in the active TB case, but somebody who's got hidden TB, or somebody who's going treated, and treatment is for at least 6 to 8 weeks to begin with, and then you again do the sputum test. If the test is negative, there's no need to worry about sharing the utensils. But to begin with, at least for the first 4 to 6 weeks of active TB treatment, one has to be careful in sharing the utensils and other things, airspace as well, and that has to be sort of looked at, especially for the people who are living in the same quarters. And it's because it's getting more into a corporate life. People are sitting in the same office floors with the small cabins and small places. Again, they can be transmitted. People traveling in the aeroplanes, or say they traveling by trains and tubes, which is a bit rare here. Still, you can transmit them. But again, that only, I would again emphasize, implies to people having active tuberculosis, not for the hidden or treated TB. So we don't need to target them, we don't need to marginalize them. If they are treated, and if they are on the treatment for 4 to 6 weeks, if they're sputum negative, you don't need to worry. It's only in the first few weeks when they can actively spread the TB to the other people.
Right. Preventive measures, what are they? Vaccines? And
yeah, I think vaccines-wise, we all know that we get the vaccination known as BCG. And the BCG is the vaccination which is recommended in the countries where the TB is still endemic. And that applies to us, people living in the subcontinent. So that is the first thing we normally have to have in first 4 to 8 weeks of our life. So we all have that scar on our left arm. So that is the BCG vaccination, which is given for prevention. Then once you are age more than 35, then there is little role of BCG vaccination. So say if somebody is being diagnosed with TB, and the other family members want to have some vaccination, there's no point in giving vaccination to the people who have been infected. You have to treat them. People who are in close quarters, if they are aged less than 35, then there is a potential role of giving them BCG vaccination again. Then again, that doesn't apply to the country with the high endemicity, but people living in the US or in the West, the prevention is in terms of giving 1 or 2 anti-TB drugs as prevention. But that doesn't apply to us because we are a high incidence country. So the problem is, if you give 1 or 2 drugs, there's a high chance of resistance. So you only wait and watch till you get inactive symptoms, and then you treat them with the full drug treatment. Now, just to add on, the full treatment is 4 drugs to begin with in the first 2 months of the treatment.
Okay.
And we are using the 4 drugs because we know it's a very clever bug. It's not going to go away so easily, and that's why we're using 4 different antibiotics to attack it from all the ends. And in the first 2 months, we give it 4 different drugs, and after the first 2 months, you give only 2 antibiotics to complete it for 6 months. And the reason we prolong the treatment is that we want to ensure that all the organisms hiding in the granulomas, they completely being cleared up and being destroyed by the anti-TB drugs. And that's why we prolong it, to make sure that it covers their half-life.
Okay. You know, as we were speaking about myths as well, you hear lots of times, you know, people saying that somebody got tuberculosis because they were really sad or they were depressed. Does depression have a role here?
Again, I think it's a very interesting question. It's a very interesting myth. You know, there is a link between depression and your immune system getting low. Okay, but it doesn't mean that all the people who get depressed, they would get immune deficiency and they would get the TB as a result. Now, you get depressed for many reasons. You know, either your health is not good, or you know, you're living in a socio-economic background which is not good, and hence these few other things which are more sort of evidence-based, more common predisposing factors for the TB. So, you know, the important predisposing factors for the TB is if you're living in a socio-economic background. So, say you're living in slums or suburban areas, or living in close quarters, where the sanitation is not good, where the ventilation is not good. That would depress probably anyone, but you do have risk factors for tuberculosis in those pockets, and that's why these people are more prone to it. But per se, I don't think that feeling sad or depression in a normal, healthy individual
There's also
would cause TB.
you know, a relationship where people say, you know, if you worry too much, you're going to end up giving yourself tuberculosis. you hear that as well, so you would sort of wonder where these myths come from.
I
And
think
how
there's
much
no scientific link to that.
Right.
And
Okay.
as I've said, depression, if it's an endogenous, that's something different. But normally we get depressed because of many other reasons around
Right.
us.
And it can compromise
And
the
that
system.
can compromise the system, and that can
Okay.
predispose you to the tuberculosis.
Okay, so here we have somebody who's been diagnosed with tuberculosis, and there, you know, people around him or her know. How does society react towards them, and what sort of problems do they face in terms of stigma and that?
It's a very challenging situation for the patient, and especially for the people living around them, because TB is a deadly disease. It can kill people. And more importantly, it can debilitate people. You know, it can make them emaciated, it can make them weak, they can lose their jobs, it's the financial worry and the burden, and plus the duration of treatment is quite long. And then the side effects of the drugs are too much as well. So definitely it's worrying if you're working and living with someone who's got active TB. Now, I think, you know, the worries are there, but there are always solutions to it. And importantly, if somebody has got active TB, they have to take the precautions, which is primarily to ensure that they limit the exposure of the droplets and the secretions to the other people. And that might involve restricting themselves for at least 4 to 6 weeks at their own.
Okay, a sort of quarantine.
It's sort of quarantine, and you know, living in a place where it's a well ventilated, may not be sharing the same office, may not be sharing the same room with other family members, covering their face with a mask, and trying to make sure that they wash their utensils and other things before, you know, they start using for themselves. Preferably to use separate utensils in the first few weeks of treatment. And the other family members have to take the same precautions as well. In terms of general public, I think if they're not living in the close quarters, they don't need to worry. If they're not sharing the same room or other things, then it's very, very unlikely for them to get the infection, but still they have to take the precautions.
Right. That's great advice. Okay, we'll come back to the rest of the programme. Right now we're going for a break, but don't change the channel. Hello, welcome back to the programme. Before we went for the break, we were speaking at length about tuberculosis, what exactly the disease is, how it's diagnosed, what are the symptoms. Dr. Sajjad, now let's talk about pneumonia. We hear a lot about pneumonia. Exactly what is it? How does a person end up getting pneumonia? And what are the symptoms?
Pneumonia is basically infection of the lungs. So that's simple thing. But as we know that lungs have got different components and parts. We start with the windpipe in the very top of our neck. That goes down to breathing tubes, two breathing tubes, right and going to the left lung. And then the small breathing tubes, they divide into small subsegments, which goes down to the smaller unit, which is known as alveoli. And that is the part of the lung where the oxygen is taken into the bloodstream and the carbon dioxide is taken out from our body to the air. And the infection can affect any part of that whole channel, from the windpipe to the breathing tubes, down to the subsegments and down to the small sacs or alveoli. And if we say that there's infection or inflammation of the big breathing tubes, that is known as bronchitis.
Okay.
And when it affects the windpipe, it is called as tracheitis. And when it affects the alveoli, the smaller unit, where the gas exchange happens, the oxygen and carbon dioxide shuffling their positions, that inflammation or infection is known as pneumonia.
Okay.
So that is affecting the bottom part of our breathing tube. And that is the part which is the most important part because of the gas exchange.
Right.
And hence people getting the problem with that alveolar sac, if it gets pneumonia. And as we know, whenever the infection enters our body, the defense system comes into play. And they start sort of fighting with the organisms. And when that fight happens, there's a lot of secretions and inflammatory stuff is being produced by the bacteria and by our cells. And when that fluid accumulates in that small sac, it gets clogged up with that fluid. Now, depending who is the stronger, whether it's the body or the infection, and who is going to win, the fate depends on that thing. So if the body is strong, they would get over the infection and clear all the nasty stuff out.
Okay.
And people would have a bit of, chesty symptoms and they would get better in a day or two. On the other hand, if the body is strong or the infection or the bacteria are stronger than the body is not recovering from that insult to the sac, and that leads to the fluid collection, and more importantly, it affects the gas exchange.
Okay.
And that is when the pneumonia is at its worst, I would say, not its best. And the symptoms are primarily systemic symptoms, like people getting fever.
Right, a high fever.
A high fever. And that is different from the low-grade fever, which
TB.
happens with the low-grade infection with the TB.
Right.
People get a lot of sweating, lethargy, malaise, lack of appetite. They're not feeling well in themselves. They would get aches and pains in the whole body.
Okay.
The more important thing from the TB is it's a quick-acting organism. So the symptoms would develop over, say, hours to days, as compared to weeks to months, as compared to TB. So
Would they have a cough as well?
They would have cough as well, because anything affecting whole system would make us cough, because they have receptors.
It's irritating.
It's irritating. The receptors which gets irritated with those nasty bugs or the inflammation would make us to cough. And then the specific symptoms are people would get coughing. They would bring a lot of sputum because of that inflammatory stuff coming out from the breathing tubes. They may or may not get blood in the sputum, depending how fierce the organisms are. And they would get chest pain because of the inflammation affecting the lining of the lung wall. And then they would feel breathless because of all that nasty stuff affecting the gas exchange.
And pain when they're breathing as
And
well?
the pain in the breathing as well. So in the end, if the organisms are winning, people might get drowsy. They would lack their concentration. And because of the lack of oxygen and because of increasing carbon dioxide, they might get into a coma state. So it could be something from very trivial, like fever, aches and pains, going down to what we call it a respiratory failure with a coma. So it could be something in the spectrum in between. And in terms of the cause of the pneumonia, it could be many different things, but the common things are viruses, bacteria, and it could be fungal infections. But fungal infections are more common in people who have got weakened immune system.
Okay.
So viruses are more common, and then bacteria. And then bacteria, there are different types of bacteria, but Streptococcus pneumonia and Haemophilus influenzae are two more common bacteria causing pneumonias. In terms of viruses, we talk a lot about, say, influenza, the rhinoviruses, adenoviruses. These are more common viral infections which can cause pneumonias. And the treatment is cause specific. So you have to treat the viral infection with the antiviral,
Okay.
treat the bacteria with the antibacterial, and the fungal infections have to be treated with the antifungal. And plus you have to give the supportive treatment, like giving IV fluids to replace the fluids being lost because of that inflammation. You have to give extra oxygen. Then there are things like giving them the non-invasive ventilatory support with the bi-level ventilations. And then in worst case scenario, you might have heard people going on to the ventilators for a few days because their body is not coping with all that stress, and their oxygen levels are dipping down, and they need some extra support with the ventilator for a few days till the cause-specific treatment gets their way in and starts curing the infection over the next few days' time.
Right. As always, I always go back to a few myths whenever we talk about, some specific disease. Pneumonia, lots of people associate it with, being out in the cold or catching a cold. And you say, don't go outside, it's freezing, you'll end up getting pneumonia. Why is that?
I think there's definitely a link between that. And then, there are environmental factors which thrive the organisms. And there are environmental factors which predispose us to the infection. Now, we have to appreciate that viruses, they love cold temperature. They thrive in the cold temperature.
Okay, so that explains the flu and the...
Yes, and that's why we have those epidemics coming up in the winters.
Okay.
And then in the winters, because of the cold temperature, the defense system gets slightly weakened as well because of the change in the temperature. And then the change in the temperature itself can cause a physical trauma over to our breathing tubes. So say if you're going in a very gusty, high wind, that can cause damage to the breathing tubes. And when there's a breach in the defense system, the organisms have a chance to sneak into the mucosa or the lining of the lung walls and to start to multiply and thrive. And they get all the things they love. They've got good temperature, they've got secretions, they've got food from the individuals. And again, the question is how strong the patient is. And hence, people who are at the extremes of ages, like infants, kids, and elderly, they are more predisposed to these infections because their defense system is weakened.
Right.
Then people who are on different medications which can affect their immune system, they are more prone to pneumonias. Then people with other medical conditions like heart conditions, diabetes, kidney conditions, and more importantly, lung conditions itself, like asthma, COPDs, they are weaker. And hence they are more prone, and infection can easily damage and target their lungs.
Right, okay. So, you've mentioned a lot that here comes the bacteria, here comes the viral infection, and then there's a battle going on inside. So there's a lot of emphasis on the immune system, because you've said again and again, and all the doctors who come on the show do say this, they repeat this. If you have a strong immune system, you'll be able to fight this. How do we develop a strong immune system? What are those things we should be mindful of, especially in diet and lifestyle?
I think I would try to sort of make it more practical for the audience, and just to sort of go back to where I said people who are more predisposed. So we'll talk more about them and then talk about the general public in a second.
Okay.
People at the extremes of ages, kids age more than 65, pregnant, people with predisposing lung conditions like asthma, COPDs, bronchiectasis, people with heart conditions, people with diabetes, and pregnant. These are people which ideally they should get influenza or flu vaccination jab every year.
Okay, and what time of the year should they
It
get
should
that
be in September, October time.
Right.
And WHO try to develop the vaccine every year based on the strains from the last year.
Okay.
Okay, so there's a good chance that those organisms would come back this year, and hence 70–80% of the time you'll get protected. Having said that, if there are new strains being developed in the new year, then they may not be giving you a foolproof 100% protection. So these group of people, and other people I would suggest is the medics working with the sick patient. They should be having influenza vaccination every year.
Right.
And then there's a pneumococcal vaccination, which is against the pneumococcal bacteria, which should be given every year to this group of people.
Okay.
Now, coming to the general public, I think that the message is that we should have to eat healthy. And eat healthy is sort of a 5 a day, and that is predominantly on the having a portion of a fruit, a vegetable, plenty of fluids throughout the day, and then the fresh juices, and then a good portion of the meat, another thing, just to boost your immune system.
Okay.
With the multivitamins and the nutritions which are required for the whole body, and as well as for the immune system. And in terms of specific protection, if somebody is predisposed, then they have to take the vaccination every year, just to ensure that they don't get the common organisms. And then I think the environment is something which is unfortunately not in our hands, but you know, we talked briefly in the last program about the smoke, and then we talked today about the environmental physical damage to the breathing tubes. So all these things you can minimize the contact by having less exposure to the pollutants in the environment, by reducing your exposure and going outside the closed environment, just to minimize the damage by the pollutants. So I think, just to recap, it's the vaccination, having healthy food, and I missed about the exercise. You know, exercise every day is going to boost our immune system.
Right.
And then, you know, lastly, to minimize the exposure to the environmental pollutants would boost our immune system as well.
Right, fantastic. That's very informative. Okay, chronic obstructive pulmonary disease, COPD. What's that?
I think it's a difficult question to answer.
Okay,
It's a broad medical term, but as the name implies, we'll go by the wordings itself. Chronic is something happening over a long time, so months to years. Obstruction is, you know, nature has given our breathing tubes a lot of elasticity. They've made the breathing tubes very elastic. And the reason it's elastic is that with the different changes happening in the environment, the nature wants to ensure that the oxygen goes in and out and carbon dioxide goes out. And pulmonary is pulmonary, it's lung, and disease is disease. So disease is something not functioning. So the main key question is obstruction. Okay. So something happening over a long period of time, which makes our breathing tubes solid or hardened and less elastic. And when that happens, as a result, as I've mentioned briefly, it would affect the oxygenation, because the gas exchange won't happen very good. But more importantly, it would affect the ventilation component, which is basically getting rid of the toxic gas carbon dioxide from our body, because that requires the elastic tubes. And if there's no elasticity, if the tubes are frozen, the carbon dioxide won't go out from the body. So it's a chronic condition which affects the elasticity of the breathing tubes, and that reflects itself in form of increasing shortness of breath and impaired ventilation with buildup of the carbon dioxide in the body.
Right. So who's more at risk of getting this, and how much of a problem is this in Pakistan?
It's a fairly common problem, and the realization is not there. It's more prevalent in people who smoke.
Okay.
Now, smoke could be a cigarette. It could be an industrial exposure to a pollutant. And in our setup, the population we are seeing is the unfortunate female group of population living in the rural areas, who are doing their cooking on the biofuels and the fossil fuels. So the smoke is there, and that the carbon soot and the smoke going into their breathing tubes, making their breathing tubes stiff, and that over the period of 5 to 10 years, causing COPD. So more commonly, say in the West, it's due to the smoking cigarette. But that could be smoking industrial pollutant, it could be smoking biofuels. And in terms of the people who smoke cigarette, it's the more common cause, and 99% of the COPDs, they are smokers. But still 1 to 2% with no exposure to any of these smoking things, because of the genetic blood tendency, they can get COPD, but that's only 1 to 2%.
Right. So what is the treatment for this then?
The first treatment is to stop smoking.
Right,
and
right,
that is,
right,
you know, the data has shown that whatever stage of the life it is, whether you are smoking for, say, smoking cigarette for 5 years, I would specifically imply that, say 5 years smoked, you stopped, that would improve your breathing functions over the next few years of your life. And your functions wouldn't be back to the 100%, but they would try to regain themselves as much as they could do. And similarly, industrial exposure or the biofuel exposure has to be stopped. So that's the first treatment. The second treatment is that, you know, if the problem and the damage is irreversible, and if it's there, then we have different medications we give through the different inhalers, because the problem is with the breathing tubes.
Okay.
And I would like to take an opportunity of this program to give a general message to the public, and again talking about the myths. You know, when we prescribe inhalers, people come and say, oh doctor, is that my terminal disease, is the end stage, I'm going to be dependent on this inhaler for the rest of my life. You know, it's all these myths, and my answer is that, you know, I'm using these glasses, full stop. Some people might think it is dependency, but I need these glasses to drive, to do my job and walk around and so forth. And some people might think I'm dependent, but I need them. Okay, and inhalers is a medication, but it's a different route you give through. The problem is in the breathing tubes.
Right.
And the medication has to go to the breathing tubes.
It's just like taking a tablet,
taking
but
a
it's just
tablet.
the delivery is different.
And the things have evolved over the last 20 years. 20 years ago, we used to give tablets, injections, and different things. But those things will go to your stomach first, go to your blood, liver, everywhere. So they will damage all parts of your body before going down to your lungs. So in a nutshell, it's a drug given in the right mode to the right place, causing less damage. In terms of dependency, you know, it's your need. You have to use it. And it's not your end stage. This is the time to use the drug at the right time, at the right place. So the inhalers, I would like to give a message to the general public is, you know, it's the best thing to use. In the West, we have stopped using the tablets because of the side effects. So treatment is inhalers. And the purpose of inhalers is they try to improve the size of the breathing tubes and try to make them more elastic. And that would help with the gas exchange and the other functions of the lungs.
Right. So that is a very important message that Dr. Sajjad is giving, that if you've been prescribed an inhaler by your doctor, it's something that will help you in having a healthier life. So it's something not to be actually worried about or apprehensive about, but, you know, to be used in place of any other medication that you might be using. Okay, so now, Dr. Sajjad, we're coming into winter. It's going to get very cold, and of course, you know, as you said, the very young, the very old, they are always more vulnerable to diseases or problems. We'll talk about them as well, children and the elderly. And then we'll also talk about the general public. What sort of care should a person employ? What we should, you know, be careful about in the winter months?
I think it's, again, a very good question. And the precautions is, you know, sometimes myths are true as well. So going back to the grandparents think, oh, you know, you shouldn't go out in the winter without covering yourself, having your muffler or the cap, all those things. So they were sort of myths things, but they have scientific evidence. So the important thing is preventing that drastic change in the temperature. So say if you are sitting in the room where there's a heater is on, or the heating system is working with the temperature of the room around 20, 22 degrees, and all of a sudden you go out from your room to the outside environment, the temperature is 0, 1 degrees. So that drastic change in the temperature, if you're not properly covered, can damage your breathing tubes. So you have to make sure that you are well covered, protected with the muffler or the cap as per your requirements and your preferences is an important thing to do. And again, I would emphasize on healthy eating. and exercising regularly as well, because all these different things, they boost our immune system.
As you said before. Is a specific diet you should adopt specifically for the winter months? Does that make a difference?
I think it does. And again, you know, if you look at our sort of food and diet, unfortunately, it's not that healthy diet.
True.
And
I mean, in winter, you'll see a lot of people making pie and things like that, you know, so they're very high cholesterol.
You know, if you look at our diet, it's more, it's good for the taste buds.
Very good.
But
healthy-wise, unfortunately.
Unfortunately, they allow you to put more weight. For the winters, you are more indoors, you do less as compared to the, you know, spring or summer. And as a result, you put more weight, your body mass index goes up, and that would probably compromise your defense system. So I think diet-wise, you have to ensure that there's a good chunk of vegetables, a good chunk of fruits, and a good chunk of healthy, fresh juices as well. And there is a lot of debate and talk going about the vitamin D and the role of vitamin D, protection against the infections and as well as against the flu infection as well. And the vitamin D deficiency is quite common again because people are staying more indoors nowadays with a less exposure to the sunshine. And hence, one of the things like, you know, vitamin D, which if you think that you're getting recurrent infections, you have to check your vitamin D levels. And if they are low, you have to be supplemented with vitamin D to improve and boost up your defense system.
Okay, right. Let's move on to another issue, and that's pleural effusion. Sounds very technical. What does that mean?
It's again, you know, it's just to give a sort of basic concept. The nature has been very kind to us. There's no doubt. The lungs, as you can imagine, they are working all the times like our heart. There's no stopping for it. No stopping. It's not our eyes where you close your eyes or your brain, you shut it down for a few hours. And their job, like heart, is they have to continuously have to move. And to protect them, because there's a rib cage outside, the bones and the muscles. So if the lungs, they're not protected from the bones, which are solid and hard, they can damage our lungs. So the nature has protected them with a very thin cover, which is known as pleura.
Okay.
So one layer goes over the lung. If you imagine that is our lung, it goes over the lung and then it rolls over on the bones and then goes around and covers it all together. So when the lung is moving, it is actually moving in that case of a cover known as pleura.
Okay.
There's a very small amount of fluid there, about 100 to 150 mLs, and that is continuously being kept in circulation by the nature.
Okay.
And the purpose is it gives you that lubrication so that the lungs don't rub against the bones. Now, due to many reasons, if the lungs get inflamed or something goes wrong with the pleura itself, if the fluid starts to build up and collect, then that is known as a fluid collection or a pleural effusion. So that is fluid collection in that covering sac. So that is different from the lungs water, which can be due to the pneumonias and other conditions. So there's fluid collection in that sac or cover, and that could be due to many different reasons.
Okay. How would a person know? Will they have a lot of pain, difficulty breathing?
They can get all sorts of symptoms, but more importantly, when there's a big pocket of fluid pressing down, because they can't press the bones. Bones are solid.
Of course.
The lungs are flexible. So as soon as the fluid collects, it would collapse the lung.
Okay.
And when the lung is collapsed, you would get all sorts of symptoms like getting breathless, having coughing, having chest pain, and the systemic symptoms like fever, malaise, and lethargy.
Right. Unfortunately, we've come to the end of the programme. Still so much to talk about. Dr. Sajjad, it's a pleasure having you on again, and thank you so much for all the valuable advice that you've given us.
Once again, thank you very much for the invitation, and it's always been a pleasure to come down and speak to you and speaking to the audience here.
Thank you very much. Likewise. Okay, so we've come to the end of today's programme. Very, very important things were discussed. Winter is coming our way. You know, let's just be a bit more careful. no harm in being adventurous, but then let's listen to, you know, the wise words of our grandparents, parents in general. You know, the cover up. Why want to be ill and, you know, then deal with all those things later on? As we always say, prevention is better than cure. See you next week. Bye-bye. Stay happy, stay healthy.